Hi, this is Sunil Mankat from the Mayo Clinic, and it's my pleasure to be part of the ASE board review in this new era that we're in this year with the COVID-19 issue. Because of that, of course, we could not do our board review course in person, but the American Society of Echo is doing everything possible to try and deliver you the review lectures that we all put together in a recorded format, which will hopefully be of help to you as you prepare for your board exam or just want a general review of topics. One of the roles that I play at Mayo Clinic is in our cardiac intensive care unit, and we do see a lot of complications of myocardial infarction, and echocardiography really plays a pivotal role in our assessment of that. And so over the next 30 minutes, I'll take you through some of these complications, which are favorites on the board exam. And I have no disclosures or off-label use of any materials. And like I said, echocardiography in acute MI is the ideal imaging modality to detect complications. It's non-invasive, it's portable, low risk, you can do serial comparison studies, and information is quickly available. We'll start with a case, and I know this is a recorded session, so the question that I ask is going to be more rhetorical, but it's just to get you thinking as you look at this video. This was a 62-year-old male who presented with an anterior wall STEMI. Unfortunately, he presented late, and only 6 hours after chest pain onset were we able to do reperfusion therapy with primary PCI. His troponin T did go to 3.2, which is a pretty sizable rise in his troponin. So here we see his echocardiogram. It's an apical two-chamber view, and I think we can all see the regional abnormality here at the apex. The calculated ejection fraction was 36%. This was performed 48 hours after the PCI. There still could be some stunned myocardium, but nonetheless, he presented late. So the question in your mind is, what is the incidence of LV thrombus despite dual antiplatelet therapy over the next 3 months? In other words, this is a patient that had a sizable MI. We put in a stent, and he's on dual antiplatelet therapy. Is he still at risk for forming a thrombus? Is the risk less than 1%, 2 to 5%, 6 to 10%, or greater than 10%? Well, it's really quite interesting. And as it turns out, there's substantial risk of a thrombus forming over the next 3 months. So it's important to do serial imaging studies to make sure that didn't occur. Even with dual antiplatelet therapy, there's still about a 10% chance. Here's a stem cell research study, and this is one of many in the literature that looked at 100 patients that did serial imaging with both echo and cardiac MRI, and they found that in 15% of the patients that had significantly reduced EFs, a thrombus did form. So you do probably have to do some serial imaging if there is persistent LV dysfunction. Now, depending on when you do your echocardiogram, it may just be stunned myocardium and it may recover. But it's not unreasonable when you see that patient in follow-up in 1 month to do a limited echo just to make sure that their EF is still reduced. It may help you decide what medications to add. And in addition, that there's no thrombus present, because then they might benefit from short-term full anticoagulation. So LV thrombus does still form even with dual antiplatelet therapy when there is significant LV dysfunction. Now, here's an example, and once again, this is the Mayo Clinic or ASE type B format, so the ventricle is on the left ventricle is on the left, and you can see here in this region of akinesis of the apex, there's a well-demarcated left ventricular thrombus. Here it is in the 4-chamber view, here it is in the 2-chamber view. The apex is notorious for the location where thrombi form because there's oftentimes stagnant flow there in the setting of an anterior apical MI. Thrombi usually form when the EF is less than 30%, and there is a risk of emboli. It's very important that you differentiate that from tubeculations, so you really need to look at it in multiple planes. Now, when you see something like this on your transthoracic echo, you want to start the heparin even before you finish the echo. You're really very nervous because this is a highly mobile thrombus that's present. It turns out this was not an acute MI, but rather a recent MI, about a month old, and this patient developed a thrombus. And you'll also notice something else. The patient was on treatment, and notice how the center of the thrombus is echo-free. And that's because thrombi lyse from the inside out. And that's something that we didn't really totally understand until we started doing more 3D echocardiography. Now, here's that patient I showed you just a little bit ago where we asked the question. And I think you can see here the regional abnormality very nicely on this apical two-chamber view. And probably to most of you, to the discerning eye, in the short axis at the apex, we're very nervous that there's something wrong here, that there is a thrombus present. But look at how much easier it is to make the diagnosis once we give an enhancing agent, contrast echocardiography. We now see this well-demarcated thrombus. There's no perfusion of that mass or that defect, and that points towards it being a thrombus, and we can see it much easier. So contrast echo can be very helpful when you're not sure if there is a thrombus or not. Now, one thing the board is going to want you to do is to be able to separate out left ventricular aneurysm from a pseudoaneurysm. So here on the left-hand panel, we see a left ventricular apical aneurysm. We see an expanded akinetic to dyskinetic apex, but very important, the neck going into this expanded region is quite wide compared to the expanded area. In comparison, we see a left ventricular pseudoaneurysm here. And now, once again, there's a thin, expanded akinetic to dyskinetic region in the apex, but the neck going into that opening is much more narrow in this particular case. The ratio diameter of entry to maximum cavity is less than 0.5. That narrow neck is really the key to the diagnosis, but sometimes it can be a little difficult. For example, here initially when we see this infrabasal expanded akinetic to dyskinetic region, we think to ourselves, oh, look, it's a narrow neck. Oh, but not so fast. When we look closer, we see this is the pap muscle. The actual neck into the entry here is actually quite wide. And that neck is really pivotal to make the diagnosis between an aneurysm and a pseudoaneurysm. Now let's get back to our case of the pseudoaneurysm, and you can see color Doppler can be very helpful. It shows us flow into and out of this expanded area. And we can see that it is indeed definitely a narrow neck. We can zoom in on it with color Doppler, and you can see that area a little bit better. And contrast echo can be very helpful here too. In this case, we've left the mechanical index a little bit higher, so the bubbles are being destroyed, so we can see the flow into and out of this pseudoaneurysm. But the size of the neck going into that thin expanded region is really the key to differentiate the two. Now, why is it important to differentiate the two? Well, in the case of an aneurysm where there's a wide neck, you still have all three layers of myocardium that are present to keep blood in the ventricle. It becomes fibrotic, it becomes a scar. There could be a thrombus present within an aneurysm, but all three layers of the myocardium are present. In the case of a pseudoaneurysm where there's a narrow neck, now the only thing keeping blood in the cavity is the pericardium. There's no myocardium or fibrotic scar to keep it in. So acutely, this is at a much higher risk of rupture than an aneurysm. Here is our case of the LV pseudoaneurysm, just to show you how when they cut the pericardium, blood readily flows out. The only thing keeping this patient from having a myocardial rupture is that thin layer of pericardium. Now, here is an example of, once again, an aneurysm with a wide neck and a thrombus. And just to show you, 3D echo can be helpful here as well. You get an acoustic signature that's quite a bit different than normal myocardium. This is an 86-year-old male who had a STEMI. You can see there's still some residual ST elevation that's present. And he presented with this echo. And you can see here, it's a pseudoaneurysm. There's a rupture and flow into and out of this thin expanded area. But it's so irregular here, we were very concerned that this could be a ruptured pseudoaneurysm. And in fact, here's a short axis view showing us this irregular area. And when we give contrast, not only is there flow into the pseudoaneurysm, there's flow outside the pseudoaneurysm. In fact, the only thing keeping blood in the heart was the scar tissue that was present in the patient's chest from his prior coronary artery bypass surgery. Amazingly, this patient did well. It turns out that over time, pseudoaneurysms can harden. So if you don't discover the pseudoaneurysm until several years out from the patient's myocardial event, the risk of rupture may be quite a bit less because that pericardium becomes quite fibrotic and hard, and it's much less apt to rupture. But if you make the diagnosis early on after the myocardial event, the usual treatment is urgent surgical repair. However, with an aneurysm, it's rare that you need surgery. The usual treatment is conservative unless there's refractory angina, heart failure, or ventricular arrhythmia. And the neck is really, really crucial to make the diagnosis. You certainly can do multimodality imaging, such as cardiac MRI and CT, but contrast echo can be helpful too. All right, let's move on. This was a 78-year-old woman. She presented with chest pain and evidence of a non-STEMI by biomarkers. Her EKG just showed non-specific changes, and her echoes showed some lateral hypokinesis, but overall the EF was preserved. She was taken eventually to catheterization, and it was shown to be an occluded diagonal as the culprit. She had some moderate disease, but because of her age and her wishes, the decision was made to go with medical treatment. But suddenly, 48 hours after her admission and her acute event, she has worsening dyspnea with sharp, atypical chest pain. We did an echocardiogram. Once again, this is the American Society of Echo Type B format. So here's the LV. You see a new pericardial effusion that's present. And when you zoom in on that area, we see another finding, or coagulum on the epicardial surface of the patient's heart. So a new pericardial effusion and coagula that's present there. In the right setting, you have to be very concerned about myocardial rupture in this setting. We don't see any flow here by color Doppler in this particular case, but that's because it's kind of tamponaded off, and it was a very small rupture that was able to be contained. She was taken emergently to the operating room, and here were the findings. You can see within our cardiac surgeon's hands the true myocardial free wall rupture that has occurred. The coagulum on the visceral epicardial surface and the new pericardial effusion was really the key. So important, about a third of patients with myocardial free wall rupture may have a subacute presentation, and you may have time to get those patients to the operating room. We've done this on dozens of occasions now over the years, where they present with hypotension, nausea, pericardial chest pain. They just cannot get comfortable sitting in bed. And you see this new pericardial effusion and coagulum. You have to be very concerned about myocardial rupture and at least get your surgeons involved right away to help in the decision-making process. Here's an unfortunate gentleman that we took care of in the CCU that not only has coagulum in the pericardial space from a rupture, he actually has coagulum tamponade. You can see that the right ventricle here in the subcostal view is completely being compressed. Large amount of coagulum in the pericardial space in this patient with a myocardial rupture. He did have a blood pressure, but unfortunately, because of comorbidities, our cardiac surgeons didn't feel that he was a surgical candidate, and we treated him with more comfort measures. So myocardial rupture occurs in about 1% of myocardial infarctions. It accounts for 8 to 17% of deaths. It's more common in women, hypertensive individuals, and older patients. It usually occurs when there's a single vessel coronary disease. And usually, unlike those 1/3 of cases that I just showed you, there's no clinical warning signs at all. It results in sudden cardiac death. Here's the more typical presentation of a myocardial rupture. This was a 65-year-old man. He had an infralateral MI. He underwent intervention. His EF is only mildly reduced. And we can see here that there is clearly a regional wall motion abnormality involving the posterior wall. But overall, the EF is not too bad, just mildly reduced. He's getting ready for discharge 2 days later. He's straining, trying to go to the bathroom, and suddenly develops syncope. We come and emergently do a stat echo during the code, and you can see here once again, coagulum tamponum. And this patient was not able to be resuscitated. That's the usual way myocardial rupture presents, sudden cardiac death. But don't forget about the subacute cases, because if you catch those, you do have time to get them to the operating room if they're a viable surgical candidate. And here, unfortunately, was this autopsy specimen of our patient. You can see with the infralateral MI and myocardial rupture and coagulum tamponum. Now, if you can't make the diagnosis of a myocardial rupture by transthoracic echo, don't be shy to move on to transesophageal echo. Here's just such a case. Now, we were very suspicious because there was some coagulum and a new pericardial effusion, but then with TEE, we were actually able to demonstrate the flow. Zoomed in view here showing you that. And the patient was taken to the operating room. All right, let's move on to other complications of myocardial infarction. This is a very seminal paper from Dr. Hoffman in New York City, the SHOCK trial, 251 patients from 19 centers. You can see that overwhelmingly, the number one reason that people present with shock in myocardial infarction is pump failure. And usually that's in the first 24 hours or on their presentation. But there are these rarer entities that can occur, and echo can be very helpful in making those diagnoses because it changes our management both medically and surgically. Here's an example of a ventricular septal rupture, or VSD. We can see this patient's had an apical MI, and then we can see this irregularity in the interventricular septum. It's quite serpiginous. Zoomed in, we can see this irregularity, this defect very nicely. Notice how it's not straight across, as is often the case. It is very serpiginous. And we see flow here from the left ventricle into the right ventricle. In addition, this patient has quite a bit of tricuspid regurgitation, so it's very important that we separate the peak velocities of the two so we know the true pulmonary artery systolic pressure. But this is a ventricular septal rupture or defect. It essentially is a myocardial rupture. It just occurred in the ventricular septum into the right ventricle. The incidence is about 0.2%. In the GUSTO-1 study, when we give fibrinolytic agents, it occurs usually in the first day. Predating fibrinolytic therapy, it occurred between days 3 and 5. Mortality is very high. 74% of patients die. Interestingly, in the GUSTO-1 study, this is non-randomized observational data. Those that were taken to surgery early had a better outcome than those that were medically treated. Now, clearly, those that were taken to surgery probably had a selection bias. They looked more viable. They were felt to be able to survive surgery. But nonetheless, what we used to do of letting people self-select themselves and seeing if they lived a few weeks and then operating is not really the practice anymore. While it's true, the myocardial tissue in this setting of myocardial septal rupture is very necrotic and difficult to sew into. If they start developing shock or end organ system dysfunction, you really have to make a decision as to whether you can fix that surgically or in the cath lab sooner rather than later. VSDs are associated with the older age, anterior MI, being a woman, and interestingly, no prior smoking. Now, we do have other approaches besides surgery that are available, and the location of the VSD is really crucial. Here's an 84-year-old woman that on the 5th day post-MI suddenly has pulmonary edema and a loud murmur. And you can see she has a defect here in the distal ventricular septum, and there is indeed color flow. This is a VSD. Now, ideally, if we're thinking about a device closure in the cath lab, we'd like that VSD to be right here in the middle. And once again, if they're doing okay and you can support them and allow that necrotic tissue to heal up a little bit and become more fibrotic, that's more ideal to be able to accommodate a ventricular septal defect device. But sometimes you don't have that opportunity because they're developing end organ system dysfunction or they're in shock. An intra-aortic balloon pump can be very helpful in this setting to help you buy some time. Our patient went to the cath lab after a multidisciplinary discussion. She was not felt to be a good surgical candidate because of her age and had an excellent result with a VSD closure device. So you really need to have that discussion with the heart team when you discover a VSD post-MI and decide what the best treatment option is. As you can see here, this patient did quite well. There often is a residual leak. It's not a perfect fit, but nonetheless, you can certainly reduce the volumetric burden on the patient. Now, the location is very important, just like in real estate. Here's a case of an infrabasal ventricular septal rupture, but look how close it is to the mitral valve apparatus. And also look at the size of the defect. It's quite big. It's not a good location for device closure in the cath lab because of that basal location and the size of the defect. Ideally, you'd like it to be in the mid-ventricle for the cath lab procedure. Not too far distal, not too far basal, but these are the things that you have to discuss and look at. Here's a transesophageal echo on a patient with a ventricular septal rupture. You can see that there's an apical MI, and you can see the irregularity here in the interventricular septum. But it shows us one of the ominous signs about thinking about taking this patient to the operating room, and that is significant right ventricular systolic dysfunction. And you can see by color Doppler to the discerning eye, there is bidirectional flow. You can really see that when we did agitated saline contrast. You can see the bubbles clearly go across from the right to left direction during part of the cardiac cycle. This patient had high right ventricular pressures that exceeded the left ventricular pressure, at least for a portion of the cardiac cycle. But RV dysfunction definitely increases your surgical mortality. All right, let's go over another entity that you may not have heard of, but echo will be very helpful in making this diagnosis. This is a patient that had a motor vehicle accident, 66-year-old man. He lost consciousness and is confused. He had multiple injuries. There's an open compound fracture of the right leg. There's a closed fracture of the left leg, multiple chest and back injuries. His blood pressure is okay, but he's a little tachycardic and he is in shock. His lactate is 6.8. He's getting a CT scan in the trauma bay, and then he suddenly complains of severe chest pain. His blood pressure suddenly drops. A stat EKG is done by our trauma orthopedic team, and there's a subtle abnormality in the anterior precordial leads, as you can see here. A massive anterior wall myocardial infarction. We have a discussion with our orthopedic surgeons, and they wrap up the legs and the injuries as best they can. And there's agreement that because of the size and degree of this anterior wall STEMI that we need to revascularize. And that's what we did. We took him for emergent coronary angiography, and you can see a stumped off LAD right there. Not much disease, moderate disease in the right coronary artery. There is a lesion here in the circ system that we fixed a few days later. But acutely, this is the culprit lesion. And the patient generally had a good result with good flow in the majority of the vessel. There was some distal embolization, slight decrease in flow in the distal LAD, but at least for most of the LAD, there was excellent flow. But despite that, he continued to be in shock, with blood pressures as low as 50 millimeters of mercury. He's intubated and sedated. A balloon pump is placed. He started on dopamine and norepinephrine. He's given fluids and blood, but he has persistent hypotension. And we did a quick look transthoracic echo. Now, he didn't have any apical windows or peristernal windows due to his trauma, but subcostally, you can see just a tiny pericardial effusion, and the right ventricle didn't look too bad at all. The IVC was small. Here's the best we could get of a short axis view of the left ventricle. You can see the RV is doing pretty good. So we'll ask a rhetorical question again. What should we do? Repeat an ECG, CT of the chest and abdomen, repeat of that. Cardiac MRI, TE, or supportive medical care in the CCU. Well, his blood pressure is 50 to 70, so that's not going to work. If he's this sick and he goes into a cardiac MRI, he probably won't come out. And of course, this is the American Society of Echo board review, keyword echo. We're going to do a TE, because the images I showed you just weren't of high enough quality to really make a diagnosis. And lo and behold, we dropped the TE probe in, and his ventricle is not too bad. He's a reperfused anterior STEMI. There is a little bit of hypokinesis here of the septum. When we go to the long axis view here, once again, left atrium above, left ventricle below, we see here a dynamic left ventricular outflow tract obstruction from severe systolic anterior motion of the mitral apparatus. And in fact, there's early closure of the aortic valve. It's barely opening because there's just not much stroke volume going across that aortic valve. Severe SAM. In fact, here's just a zoomed in view showing you the SAM, the turbulence in the LV outflow tract, and moderate mitral regurgitation. In the deep transgastric view, when we measure the gradient across the left ventricular outflow tract, we had a peak velocity of 5.8 meters per second and a peak gradient of 135 millimeters of mercury. No wonder that aortic valve didn't open much. You can see the late peaking spectral Doppler pattern that is present, dagger shaped. So what did we do? Well, we left our TE probe in place and immediately stopped the norepinephrine, stopped the dopamine, actually removed the balloon pump and gave volume. And lo and behold, the SAM virtually resolved. Our aortic valve is now opening much better. The mitral regurgitation got better as well. And we can see here that this patient had an entity called dynamic left ventricular outflow tract obstruction that can occur in the setting of an apical myocardial infarction, anteroapical. You can see the gradient across the LV outflow tract before we initiated our therapeutic maneuvers, and then afterwards, there's no gradient whatsoever. And here's the final result of his LV. You can see there is some hypokinesis, but overall, his EF is well preserved. And I'm happy to report that patient did very well. We opened up his circ a few days later. He had his trauma injuries fixed. So this entity of dynamic outflow obstruction in acute MI with shock is something that is well reported. Here's an example from transthoracic echo showing us this apical abnormality. And because the apex is akinetic, the basal segments become more hyperdynamic and hyperkinetic. And that creates a milieu that can lead to dynamic left ventricular outflow tract obstruction. There is a lot of mitral regurgitation, but it's flow in the LV outflow tract with this late peaking, dagger-shaped, obstructive pattern that's really the key to the diagnosis. But it's something you really need to look for. Here, once again, is the SAM. And if you look for it, you will see it. And this has been well reported by several friends of ours. You know, we're partial to the Michigan group, and Bill Armstrong, who's a good friend of ours, reported this back in the mid-90s. But the basal segments become hyperkinetic, and that creates a milieu that can lead to SAM, or systolic anterior motion of the mitral apparatus. Now, this can also occur in apical ballooning or a mimicker of an MI. So here we have a patient that had normal coronaries, but has apical ballooning, but is in shock. And about 10% of apical ballooning patients will be in shock. And one of the reasons that can occur is dynamic left ventricular outflow tract obstruction. And you can see here the SAM that's present, the turbulence in the LV outflow tract, the mitral regurgitation that's posteriorly directed, and the classic spectral Doppler pattern. Difficult to treat, volume, beta blockers, but it will definitely get worse with some conventional maneuvers, such as a balloon pump, dopamine, etc. All right, here's a 62-year-old woman with chest pain and severe pulmonary edema as shown by her chest X-ray. This is from my former mentor, John Gorson. And you can see here a beautiful example of a papillary muscle rupture. Left atrium, left ventricle, here's a torn chordae, and the head of the papillary muscle shown right there with severe eccentric mitral regurgitation. There's that chaotic motion that we see with a rupture of the papillary muscle head. And now a 3D view from the left atrial perspective, the surgeon's view. Here's the head of the papillary muscle. And here's a transgastric view. There is an inferior regional wall motion abnormality. It will become even more prominent once you fix that papillary muscle rupture. And just to show you that 3D again, you can see that multiple torn chordae here. There's this time off the posterior mitral valve, and there's the head of the papillary muscle. This patient underwent surgical mitral valve replacement with a good outcome. So papillary muscle rupture does occur. It's a loss of papillary muscle integrity. It typically occurs 3 to 7 days after the myocardial infarction. It's hemodynamically the most serious mitral valve complication. Most commonly involves a small infarct of the RCA or circumflex or an infralateral MI. And that's because the anterolateral papillary muscle has a dual blood supply, whereas the posteromedial papillary muscle does not. We have seen cases of RV infarcts with papillary muscle rupture as well. Just to show you the gambit, the different spectrum, here's a case from the archives that shows a much bigger head of the papillary muscle rupture, this time on the anterior leaflet, not the posterior leaflet. So even though it may involve the posterior medial papillary muscle, it sends chordae tendineae to both leaflets. And in this case, there's torrential or massive mitral regurgitation. It's all you can do to get this patient to the operating room. And then hopefully we'll get a surgical repair. Here's another patient, just to show you the spectrum. This is a sad case. This was a patient who broke up with his girlfriend, and he was actually moving her piano out of their home when he had a heart attack and also had a papillary muscle rupture. He presented to us with pulmonary edema in the setting of this heart attack. And in this case, not only the anterior leaflet, but the posterior leaflet. Both leaflets are involved with this papillary muscle rupture, and there's the head of the papillary muscle. Remember, both leaflets can be involved irrespective of which papillary muscle ruptures. Torrential mitral regurgitation. I'm happy to report that Dr. Joe Duraney at our institution repaired this patient's mitral valve, and his outcome from a cardiac standpoint was very good. But unfortunately, even though we could repair his mitral valve, his relationship could not be repaired. One other entity that you need to look at from echo is a partial papillary muscle rupture. This is a ticking time bomb, and moving quickly is really crucial. We see here anterior leaflet override, but when we look closer on the ventricular side of the mitral apparatus, we see this chaotic motion of the papillary muscle. In this case, it's the anterolateral papillary muscle. We see the regional wall motion abnormality that's present. But that chaotic motion is really the key. You can see it just wiggling right there. And I think I said anterolateral. It's actually the posterior medial papillary muscle. But it's going to the anterior leaflet. So remember, it can go to either leaflet. And we see here the classic chaotic motion of a papillary muscle rupture. You need to recognize this. This is an emergency. There may be severe mitral regurgitation, but in a few moments, that papillary muscle will completely break, and then there will be torrential mitral regurgitation. The patient will be in shock and probably severe pulmonary edema, and it'll all be up to you to get them to the operating room in a heroic fashion. Whereas if you make the diagnosis ahead of time, it's a much more stable situation, and there's a much better chance to get the patient safely to the operating room. And don't forget, there can be eccentric mitral regurgitation, but the PISA here really tells you the story that this is a very significant check of mitral regurgitation. But that chaotic motion that we saw on the ventricular surface of the mitral apparatus is really the key. It had not quite broken free and gone to the left atrial side of the mitral valve, but it was only on the ventricular surface that we saw that. And this patient underwent successful mitral valve repair. Now, unlike VSD, that carries with it very, very significant surgical mortality. When we looked at the Mayo Clinic data, this is from Maurice Serrano at our institution, you can see here that although early on there was a very high mortality, later on, when we started doing bypass grafts, the mortality was down to under 10% in the more recent operated on patients. And overall mortality was about 20%. And more importantly, if you lived after surgical treatment of a mitral valve papillary muscle rupture, your outcome was just as good. So maybe at 20%, maybe lower than that, 10% surgical mortality nowadays. But if you live, your outcome is just as good as patients who had an MI that did not have a papillary muscle rupture. So making the diagnosis is really crucial. So 3 different entities, a VSD, pap muscle rupture, and dynamic LV outflow obstruction, all can cause a very loud systolic murmur post-MI. Patients are often in shock in a low cardiac output state. These 2 are treated surgically, whereas dynamic outflow obstruction can often be managed medically with fluids, beta blocker, and an alpha agonist. And the only way you make that diagnosis is with echocardiography. So one final complication. This was a patient with an inferior wall MI that also had severe RV involvement. Now watch this complication closely. There it is, caught on echo, ventricular fibrillation. This occurred during my time in Pittsburgh, and I was a tough taskmaster. I had my sonographer shock the patient and then continue with the study. And you can see here severe RV dysfunction that's present. Now, we used to treat RV infarctions with central catheterization, central lines, pushing the CVP up to 13 to 15, giving a lot of volume, but not too much volume because of ventricular septum to shift too much from the RV towards the LV. Often now, though, we can manage these patients with serial echocardiography or point of care echo at the bedside. And clearly, this patient had a severe RV infarct, unfortunately, was not able to be revascularized. Once again, here's the ventricular fibrillation that you don't often see caught on echo. There it is, VFib on echocardiography. So in conclusion, echo is really pivotal to the diagnosis of complications of MI, from ruptured papillary muscle to free wall rupture, pseudoaneurysms, true aneurysms, mural thrombus, pericardial effusion, RV infarct, ventricular septal rupture, VSD, and dynamic outflow tract obstruction. I thank you very much for your time and consideration, and good luck if you are taking the echo boards later this year. Everybody, please stay safe.